Okay, well, hello everybody. It looks like folks are still logging in. I thought this might be a good chance to just do a little sound check. Fingers crossed. Are you able to hear me? Just let me know in the chat box. Phew, okay, good. I always worry about technology. I have a love-hate relationship with it. Awesome, guys. I just want to kind of come out of the gate and let you know that I tried to upload the handout for today's PowerPoint, today's webinar, along with the brochure for the Science and Soul Congress, but the files size is too big for the platform. So what I'm going to do after this webinar is I'll email you guys the slide deck, and I apologize for any of that inconvenience. Moving forward, I'll try and be more mindful to either keep the pictures down, which I'm not good at doing, but maybe even send it out to you guys in advance. Maybe you can let me know in the chat box, you know, which you would prefer. So just to let you know, you will get the slides after this session, and you'll also have access to the replay in case you want to double dose me. But I also put the replay, made the replay available for folks that aren't able to join the live session but were interested in the topic. There is a bit of a lag, I believe, between, you know, what I'm saying and you receiving it, and the same with the chat. So I hope it doesn't feel too bumpy, and I hope you really enjoy the content. So I've got Sharon from California. Any other Californians here? Yes, yes. Oh, great, from Florida. Cool beans. We have snow here in Massachusetts. I'm in Boston, and it's snowing and it's wicked cold. Illinois, you can probably relate to this cold weather. Oh, this is cool. Oh, thanks, Tammy. If somebody should enjoy the good weather. And I mean, I'm not really complaining. I do love the winter at Christmas time. All right, well, I don't want to hold things up too much. I've got a lot of information to share. I will, you know, try and keep one eye on the chat box. So if you have a question, please, you know, sing out. There is an opportunity to raise your hand. Be patient with me, and I'll try and keep this balanced. I do want it to be as interactive as possible. So the topic for today is a topic that's near and dear to my heart, talking really about the science and soul of trauma-informed developmental care. So I do have a poll that I want to throw out to you guys real quick. So I want to just kind of ask the group, are you familiar with the concept of trauma-informed developmental care? Go ahead and, you know, click on the poll with either yes or no. It's all good. This is not a test, just an inquiry. It's cool watching it seesaw. I don't know if it's doing the same thing on your screen. Just give you another few secs. Okay. All right. I'm going to go ahead and end the poll. Let's see. I don't know if you can see it, but it looks like 77% are familiar with it, and about 23% say no, and that's pretty average. You know, with at least with what I'm experiencing, there seems to be more and more of an uptake and a familiarity with the idea that hospitalization for infants and babies and truly anybody, is a traumatic experience. And so understanding that it's traumatizing to these individuals, the informed part is really us understanding the biological dimensions, the psychological implications and dimensions. And there's even some spiritual dimensions that I'm not really going to touch upon too much today, but we can talk a little bit more in future webinars if you're interested, obviously. So the science and soul of this is really trying to balance what we understand from a biological perspective, an epigenetic perspective, but what we also know from a shared humanitarian perspective, all right? And what I'm discovering, and I want to share with you, is that these two entities, science and soul, are not as diametrically opposed or on two ends of the spectrum as was originally thought, right? We come from a biomedical model, and I think we've all kind of grown up with a very solid foundation in anatomy, physiology, and biology. And then these concepts of spirit, soul, mind are kind of like, yeah, they're out here, and we kind of acknowledge it. But in our day-to-day work, we're so focused on this tangible entity, this tangible, the tangible processes associated with pathophysiology, with medical care, surgical care, and that sort of thing, that sometimes we miss those soulful dimensions that are so crucial and relevant, biologically relevant to the developing infant. So let me pop back over to the chat box to give you guys a chance to throw any stuff up there. And here are my learning objectives that I'm hoping to describe the effects of early life adversity on the HPA axis, talk a little bit about the prefrontal cortex and its involvement with trauma and the implications of trauma for the prefrontal cortex, and then also the implications or the impact of early life adversity on the threat detection and response system. The threat detection and response system is really talking about those limbic structures. Primarily the amygdala is a big one, but the amygdala really does interface with the anterior cingulate cortex, which is kind of a neighbor to the prefrontal cortex. We're going to talk about evidence-based best practice interventions that align with the values of a trauma-informed approach to care. And this is a new way for me to present this information. I hope you find it interesting. I will be reaching out with an evaluation tool afterwards to get your super constructive feedback on this. And then finally, I'm hoping we can engage in some discussion about the implications of understanding this phenomenon, right, of infant trauma or child trauma, and utilizing a trauma-informed approach to our clinical practice, but even taking it beyond the clinical practice and looking at our opportunities, right, as frontline clinicians, as leaders, as advocates for our patients. How can we take this information and really start revising and applying it to public policy? So coming out of the gate, let's, hit this from a super biological perspective. I was so excited to see a reference of, fudge, now I forget the great philosopher who made this quote about the whole is greater than the sum of the parts. But this quote was from this very current paper from Garcia Rieros, who really is introducing this idea of an integrated approach to our understanding of the human response to trauma, to stress, to distress and disease. And what she identified is these three systems. And what took me by surprise is that she's now identifying the microbiome as a system that's interconnected with the stress system, with the neuroendocrine system. And so the idea of this, about the microbiome, really evolved from extensive studies that have looked at the gut microbiome and how the gut microbiome really communicates with the brain. You might have even heard of the brain enteric axis. That this gut microbiome really serves as an endocrine organ. how wicked interesting is that, right? And this concept is not just her idea. It's really been suggested by a myriad of other researchers as early as 2013, 2014. We've seen some research around this. And it arises from the idea that the microbiome actually produces and regulates multiple compounds that influence distal organs and systems. And that's really what an endocrine organ does, right? You know, they're hormones, and they produce these peptides, and they squirt them out to other parts of the body to elicit a response. And that's what the microbiome does. In particular, what the microbiome system communicates with is the central nervous system, the endocrine system, and the immune system. So as I dive into this talk and really start demonstrating the idea behind the neuroendocrine immune system, or the neuroendocrine immune hypothesis, specific to toxic stress, I want you to not lose sight of the fact that the microbiome is a key player. The microbiome, just to kind of, from a definition perspective, are just those organisms that live in harmony with us, right? They arise in the gut, they colonize the surface of their skin, the GI tract and the respiratory tract, which are mere invaginations of the surface of the skin, are also colonized with friendly bacteria, right? For the most part. There might be some bad players in there, but the bad players are kept in check when we're in a healthy state by the healthy flora, if you will, of the microbiome. So this is a really important aspect that's emerging in the science to help us better understand how we respond to health and wellness, but also disease and illness. The other piece that I wanted to kind of introduce to you guys, which I want you to kind of think about within the context of this idea of toxic stress and how toxic stress activates a neuroendocrine immune response, are mitochondria. Now, I know this might sound like a throwback from, you know, gee whiz, biology in high school, when we all learned about what is a mitochondrion, and that it's the powerhouse of the cell. Do you remember this? I'm hoping you're all nodding your head, right? This is such fascinating stuff. Because I'll tell you, in my own experience, when I talk about this stuff, I don't really get right down to that organelle structure of the mitochondrion. I know that toxic stress disrupts our cellular integrity, disrupts our homeostatic integrity, and even, you know, allostasis, when we have a stress response. Healthy stress responses are, I don't think about the energy piece of a healthy stress response in general. You know, I know we have a fight or flight, but I've just not consciously thought about, well, gee whiz, where does all the ATP come from to elicit that stress response? Never mind toxic stress, right? Toxic or chronic stress. So what I'm discovering is there's now this huge body of research that's not, I mean, there's new stuff, but it's not super new. Like, this is actually, folks have been like talking about this stuff now for about maybe 5 to 10 years. But it's really starting to percolate and make its presence in the medical literature. And in fact, Picard, the author of this reference here, and Bruce McEwen, who's a guy that does a lot of really amazing research around allostatic load and allostasis, particularly in critically ill patients, are really drilling down to understand some of the cellular mechanics of this, and that the mitochondria actually is a key player at that very subcellular level, that when you see the patient in that kind of exhausted state, maybe that passed out state from, you know, overstimulation, they've had too much stuff happening, you're seeing an orchestrated response at that subcellular level that is completely systemic, right? It's not just one system that's collapsing. It's multiple subcellular organelles that are having a failure to generate enough energy for that organism or individual to tolerate a given situation. And why I find this intriguing is when I think about some of the challenges that our patients experience, not only around growth, like, you know, mass growth, you know, like when we do the, you know, the daily weight checks and stuff like that, but I'm talking about linear growth, right? Linear growth is a marker of an individual's ability to lay down new tissue, right? It's easier to put on mass than it is to lay down new tissue. this laying down of new tissue requires a huge amount of energy. And there's another paper, which I actually haven't referenced in this particular presentation, but I'd like to share with you. It talks about the energy costs of the neonatal intensive care experience on the patient, that they're constantly being taxed from a disease perspective, right? How much energy it takes for healing and recovery when they're faced with chronic inflammation. There's a huge, and there's actually a bi-directional hit that really deflates the bioenergy that's at the mitochondrial level that's available for the organism or for the individual to mount responses for repair. And so you'll see the scales tipping. So when you have toxic stress, it activates an inflammatory process that actually can overwhelm the reserves of the individual. So, and I know I'm kind of hitting you with bits of critical physiology that I think will have a bearing on the summarization of this talk in the next 45 minutes. A little bit more about understanding about this idea of mitochondrial allostatic load. And again, Picard and McEwen have looked at it specifically from a psychological stress perspective, which of course for me was amazing because I certainly understand the physiological stress perspectives of this. You know, for example, when you're looking at energy expenditure and you know, the oxygenation and phosphorylation and all those other cellular activities that you need for tissue repair, but that you are also exposed to during tissue injury, which I'll mention in a few more slides. But that psychological stress also taxes your energy stores right down at the mitochondrial level. And that when the psychological stress overwhelms the system, it becomes an allostatic load, a stress load on the mitochondria. And then you start having these issues around what they call mitochondrial dysfunction. And when you have mitochondrial dysfunction, particularly in individuals that are experiencing critical and sensitive periods of development, what happens is this dysfunction actually arrests maturation of the tissues that are involved. I hope this is making sense, but I also hope that it's raising a lot of questions. And I want you to know that I've included an extensive bibliography on this slide deck so that you can check this stuff out as well. But basically, I feel like my goal is certainly to introduce you to this stuff and pique your interest. Now, from a neuroendocrine perspective, the two aspects that I want to talk about right now is how this idea of early life adversity affects the hypothalamic pituitary adrenal axis, a key component of the neuroendocrine system, particularly looking at early deprivation, and I probably should have put /separation, all right, and also this concept of maltreatment. Now, don't get pissed off as I say the word maltreatment. I will explain myself shortly. But I also think a rose by any other name smells as sweet. And I think if we can look at some of the experiences that we create in the NICU, when you look at it through the lens of the accurate definition for maltreatment, I think it may actually, oh my goodness gracious, yes. Thank you, I'm sorry, you're right. I got ahead of myself. The slides aren't advancing. Let me move ahead. Oh, you guys, I'm so wicked sorry. Thank you. I didn't realize it was locked as I'm clicking the button. I'm talking too much. Let me just bring you up to speed. So here we're talking about the stress system, the microbiome, and the immune system. You can see over here this little ball of organisms. This represents the microbiome, and there's this bidirectional feedback with the endocrine system, as I had mentioned, and how it communicates to the central nervous system, to the immune system, and to the neuroendocrine system. As I was just mentioning, this idea of the mitochondria, really talking about how this stress impacts the organism, really spurs the body, right, to mount a response, right? To release energy so that the organism or the individual has something to respond to. You can't do a fight or flight if you don't have enough energy stores. And certainly we think about glucose and oxygen and stuff like that, but all of those stores are released hinging on the availability of energy substrates like ADP and ATP at that subcellular level. And as I mentioned, the idea of psychological stress, which I really didn't think anybody was thinking about, psychological stress as being distressing on a physiological level, but indeed it is. And this, again, kind of coming back to the title of the talk, is that soul side, right? Psychological stress, emotional distress, those are really expressions of our soul side, right? Our spiritual side of who we are as individuals. And babies have that dimension to them. And so the experiences that they have that are distressing, particularly hallmarked by deprivation and separation from their family or their mom, and or maltreatment. And when I use the word maltreatment, I am specifically talking about neglect. And again, please don't get pissed off at me, all right? I mean this with great love in my heart as I share this information with you, but I think it's also not fair for me to not be transparent in what it is that I'm trying to communicate with a sense of urgency around the care that we provide, and that we have amazing opportunities and really imperatives to change how we're approaching the care. Because when we're looking now at these short-term and long-term consequences, they are directly related to the phenomenon of separation and maltreatment, with an emphasis on neglect. Bear with me. So, some HPA facts, okay, before we get too far ahead. The HPA axis becomes responsive to stress signals as early during fetal development. So we do know that the HPA axis is functional in our even most immature patients. Prenatal and infancy periods are sensitive times for organization of the HPA axis. So again, much like what we know about the brain, that it's, when we look at the brain going kind of from that, from a mushroom state to a cauliflower state, right, with all the convolutions, that this development is happening on our watch with all of the cares that we're providing. Same thing for the HPA axis. It's actually becoming sensitized and regulated based on the experiences that it's exposed to during these premature, acute days of hospitalization. The other piece of this, the most potent stressor for a child are threats to their connection with their attachment figures. Now that's lots of words there, but it's basically separation or deprivation. And that we know early adversity or chronic adversity in infancy is associated with hypocortisolism patterns, which you might be thinking, interesting, right? Because I would think initially, and I thought on first pass, lots of stress, you're going to be squirting out more and more and more and more cortisol. So you tend to be hypercortisolemic. But in fact, what happens is the HPA axis, in the setting of repeated chronic stress, it actually resets. And so you have a lower circulating cortisol level at baseline, but you also have a lower threshold for activation of a stress response. So these are the things that we know about the HPA axis. And so I want to just kind of like segue into this idea of deprivation and separation. In the literature, we know that early adversity affects the HPA axis, and that a lot of it can be quantified by measuring salivary cortisol levels. The thing that we do know is that they're not as accurate as we would like, and they're not as accurate as we see in more mature individuals or organisms. Nonetheless, it is a great biomarker for us to recognize when an individual is having stress. We see that the presence of these stress biomarkers more highly released or present in individuals that have experienced institutionalized care. Now, traditionally, institutionalized care is a term that's used for orphanage, but it's also a term that is used in any situation where infants are experiencing child rearing over a chronic period of time in a setting other than their primary domicile or with their parents, in a continuous setting. Does that make sense? And so when you look at the institutionalized setting, just that milieu has an impact on the stress response development, reactivity, and what we see in extreme situations, that there's a blunting of the cortisol slope over the developmental trajectory of the HPA axis evolution. So what does this mean? Well, it means that, you can actually see the connection then between this early life adversity and some of the risky behavior that we see that these individuals are prone to down the road. I don't have it included in this slide deck, but there's a really cool pyramid that demonstrates the sequela of exposure to chronic adverse childhood experiences and the connection with the adverse childhood experience and how it disrupts healthy development biologically, neurobiologically, psychologically, right down to the cellular and epigenetic levels, and then how those perturbations then in the derailing of the healthy development set these individuals up for risky behaviors. These risky and of course abnormal or actually not abnormal, but increased vulnerability and susceptibility to adult morbidity. This adult morbidity that we see is physiologic in nature. So we see, particularly in NICU and PICU survivors, in NICU survivors, an increased risk of cardiovascular disease, metabolic syndrome, what they call central sensitizing syndromes like irritable bowel syndrome, migraines, fibromyalgia, those kinds of syndromes. On the psychological side, we see these individuals, and they've actually monitored them at different age trajectories. So in early childhood, past infancy, if you've had this kind of experience, a NICU experience, prolonged chronic stress, in childhood, we're seeing an increase in attention deficit hyperactivity disorder, internalizing behaviors. Those are precursors to anxiety and depression. Externalizing behaviors, ongoing depression, but with a kind of an aggressive component to it, oppositional defiance disorder, and then they follow these individuals out into adolescence, where they continue to see this this risk persists. Okay, the impact on their biology has already been set in stone, and you can certainly. And what we're going to talk about today are interventions to try and disrupt the evolution of this. But in the absence of any active interventions or active preventative strategies, this is kind of it. The die is cast, so to speak. So understanding how this experience of early life adversity and early deprivation in particular impacts the individual is pretty profound and pretty long lasting. Klaas and Gunnar talk about how the adversity undermines the capacity of relationships to provide stress buffering and emotion regulation benefits. So when an individual is separated, when an infant particularly is separated from their parent, I think we miss the fact, I get that it's medically necessary, but we miss the fact that for that first postnatal year and even up to 3 years, these infants and children are still a biological dyad with the mother. So there's a lot of social and emotional gestation and development that occurs in that postnatal period, just in healthy folks, right? When we interrupt that social and emotional development is impacted significantly. And in the setting of NICU, these relationships, in the absence of these relationships, and Monterossi and his team out in northern Italy have done extensive research about this, the buffering capacity of maternal care. When you don't have maternal presence and maternal care, particularly during painful and stressful experiences, the stress of the situation overwhelms the individual, and you'll see these individuals, they'll initially fight. For example, clinical example, think about somebody putting in a feeding tube, a nasogastric feeding tube, without the use of a non-pharmacological intervention. This is how I was taught. I don't do this anymore, but this is how I was taught. You wrap the baby up, you swaddle them, you hold them, you grasp their head, you take the feeding tube, and you just ram that right into their nose. The children often do something like this, or the babies do something like this. They're fighting for their life, right? But then, you're bigger, you win, you get the tube in, and they collapse. And you think, okay, great, they've fallen asleep, or everything's okay now because I got the tube in, and they need to have the tube, which I'm not arguing that. I'm arguing with how it was done. That relationship was threatening to that individual. There was no comforting there. It was just getting something done. If that experience is repeated, which it often is, what happens, right? Neurons that fire together wire together. And what that individual learns at that subconscious level, that subcortical level, is that the world is threatening, people are scary, there's no trust, and you have to be on guard all the time. You can either be a fight or flight mode, or you can be in that faint and flee mode, that faint and feign mode, where you're just withdrawn. Both have an energy cost attached to it. Critical to physical and emotional health in social species is the capacity to use the presence of supportive individuals to reduce fear and physiological reactions, right? They cannot learn about hope. That's absolutely right, Sharon. They don't feel it. And thank you for mentioning that, because again, when you think about from a psychosocial developmental perspective, that first year of life, from Erik Erikson's work, it's about trust versus mistrust. And if you get it right, the life virtue that emerges over that first year is hopefulness, right? But when you don't have that, right, you don't learn hope, right? You don't experience hopefulness. You don't experience trustworthiness. And so you can see now how these experiences then are linked to a high risk of suicide, depression, anxiety in early adolescence and on throughout adulthood. And those are quality of life busters. So our mission is to really recognize this. This is the informed piece, right? Being trauma informed. You're learning this, you're understanding this, and then you have to take this information and operationalize it into how you engage with these amazing human beings. Parents, particularly, are potent regulators of HPA axis reactivity. Now, that being said, right, that's a broad sweeping statement. We also have to recognize that the parents that we're serving, that we're caring for as well, are also in a state of shock and trauma, and we don't even know what their backstory is. So they have the potential to be potent regulators of the stress response in their infants, but they need to be empowered, they need to be educated, they need to feel like a partnership with us as clinicians to really fully operationalize that therapeutic aspect of their role. Right? And just from that aspect, no, but also in doing so, right, it's very role validating for them, right? So this is a very complex dynamic system that I'm sharing with you, and I'm hoping that you'll see, that this isn't fluff. There is real biology attached to this, and it is an absolute imperative that we change how we approach the care of these individuals. Now, I'm coming back to that word maltreatment. And I don't want to piss you off, okay? But from the definition, from the CDC, maltreatment is any act, intentional or not, that results in harm, the potential for harm, or the threat of harm to a child. The failure to provide for a child's needs or to protect a child from harm or potential harm is also child maltreatment. So let's think about that. What's the harm that we're talking about? Now, in the old days of neonatology, right, we had a different understanding of the vulnerability and the susceptibility of these amazing human beings. But what we now know is that, in fact, they are little humans, right? And they are greater than the sum of their parts. And they may come to us with a particular diagnosis, but that does not exclude their other needs as developing fragile human beings who are learning about the world with their encounters with other human beings. So when we do not attend to that, it's not my intention to hurt you, but you need the feeding tube. So I'm going to put the feeding tube in. That's maltreatment. If you do not use the appropriate non-pharmacological strategy, we have papers that demonstrate. I mean, you put a feeding tube in, you know that is painful and at least distressing to the patient. You have a responsibility to manage that because we know the repeated painful experiences toxic stress changes their biology right down to the cellular, subcellular, and epigenetic level. And that's the reason why I use this term, because I think it's powerful and I think it really helps shake us up and think differently about how we engage with the care of these amazing individuals. What is known, on average, and these are the references here, I'm not making this stuff up, on average, infants in the NICU experience skin-to-skin contact once a week, on average, and have a swaddled hold maybe twice a week. This is on average. Now, you guys here, you may be part of the choir and you do it all the time, and that's mwah. But on average, nationally, and actually I believe some of these are international data points. On average, preterm infants experience a high degree of pain and or stress in the NICU, anywhere from 22.9, say 23, plus or minus 2.3 procedures daily. Now, this particular reference, this is Kong, and this is not talking about only painful procedures. It's combining painful and or stressful procedures. So it could be a diaper change, it could be suctioning, it could be lead application. They quantified these procedures from the work of Newnham et al., who developed the neonatal infant stressor scale. The final point is from the EPIPAGE study, that's the Cruz reference, that painful procedures occur between 7.5 and 17.3 times per day. Known painful procedures, particularly the heel stick, I believe, or needle sticks was the particular one that these guys were reporting on, with 50 to 100% of these procedures being unmanaged for pain. So this is what we know. And you can see these dates on these references. This isn't like old school. This is like now. This is happening now. Why? That's the thing that's got me stymied. Why? Do we need more understanding about the biological implications of what's happening to these individuals? We know that exogenous stress, affects the body, right? It affects the body physiologically on the surface. We see stress responses and stress behaviors, but we know that it also happens subcellularly. I mentioned that earlier when I was talking about the mitochondria. And this graphic here I took from a paper that was really looking at or trying to explain that this mitochondrial dysfunction phenomenon isn't specific to one system. They looked at the mechanism for the dysfunction at the pulmonary level and then the brain level. And what they found is that the phenomenon or the mechanism was very similar. That this idea of an energy failure occurs in the setting of excessive physiologic stress, but then is compounded by psychological stress. And that particularly this study, the 10 study, I was intrigued with because it's talking about non-cystic white matter injury. And that area encompasses the prefrontal cortex. What do we know about the prefrontal cortex? Well, we know that it's involved in our executive function, right? It's involved in our decision making. But again, it is in a rapid state of growth and development on our watch, right, during the NICU. So again, making the connections. The brain's developing, but what does that mean? When you drill down and you get into the specifics of what these different parts of the brain, how these different parts of the brain contribute to the quality of that individual's life, the success of that individual in enjoying their life, it makes all the difference in the world. This is just an aside, but so I'm writing a second edition to the first book about transformative nursing in the NICU, which is overwhelming me, but it's also pushing me to, get more current on the literature. There was a very interesting article that looked at the psycho-emotional and relationship outcomes of NICU survivors, and that NICU survivors, former premature people, are more likely to not have romantic relationships, have sexual intercourse, or become parents. Now, I'm not saying that those things are like a panacea for the dream life, but just the simple fact that that aspect of their life is hindered by their early life experience is really, really telling about the gravitas of what we're talking about here when we're looking at trauma in the neonatal time frame. That author is Mathewson, and if you're interested in that, I don't think I reference it in this paper, but I'm happy to share that with you as well. It's an open access paper. What we know about the PFC, or the prefrontal cortex, is early prenatal and postnatal environment dramatically shapes its development. That this cortex exhibits a rapid development during early infancy, which includes changes in structure, connectivity, and function. And all of these are affected by mitochondrial allostatic load. And we know that fastest structurally growing regions in the brain, the most metabolically active, are the most susceptible to the negative effects of early environmental stress and or biological insults, right? Again, because you've only got so much energy reserves. And as I had mentioned earlier, those areas, maturation is arrested because there's not enough energy to support ongoing development of that structure. Specific to the NICU, this is a really, well, actually specific to pediatrics. So this is a really cool paper published by Johnson et al. And I apologize, I misspelled her name. It's Johnsson. She talks about toxic stress and the role of the pediatric clinician, and how this early life social environment really impacts the healthy developmental trajectory, to the point now where the American Academy of Pediatrics is now using well, it's not a modified, it's a new framework for pediatric science, recognizing what these authors are sharing with us. And it's called the eco-biodevelopmental framework. The eco is the ecology of the developing individual, and that's what Johnson has shared here: responsive caregiving, socioeconomic status, family functioning, and trauma. Affects the biology, right? That's the eco-bio, the biology. And that's really this middle bit here: the immune system, the neuroendocrine axis, and brain development are affected by this ecology, both physical and relationship or a social environment. And then the developmental trajectory, right? The health and developmental outcomes are impacted. Infectious disease risk, chronic disease risk, I mentioned this, and there's lots of papers that highlight adult morbidity, adult outcomes as a result of fetal and neonatal experiences. And so we're even getting into now fetal stress, and that's a whole other topic that we can talk about in another webinar if you're inclined. The mechanism for this is, so there's been lots of talk about, like, well, how does this all happen, Marian? How are you tying all of this together? Because you're giving us a lot of information. And so the new hypothesis now is this idea around inflammation, mediated by neuroendocrine activity and immune activity, and modulated by a perturbed microbiome. And so you can see here in this first column, when you have this early life stress, you've got elevated cortical amygdala threat sensitivity. The organism, the infant, is on high alert. They don't know when the next shoe is going to drop. Somebody could be popping through those portholes any second now, because we haven't created these routines, these rituals around engagement with the infant. Just like when you knock on a patient's door in an adult setting, don't knock on the incubator door, but there's a way that we introduce ourselves before we, flip up the, bring down their bed sheets and do a, flip up their Johnny and do an examination on them, right? It's as simple as that. So the interventions, there's no cost to them. There may be a mild time cost, and that's about it. But when we've got this system super jacked up, what happens is a low-grade inflammation is set up at the microglial level. So that's at the central nervous system, specifically in the white matter, but also peripherally. There's this low-grade inflammation. And what does inflammation do, right? The cell walls get boggy, right? There's lots of exudate at that cellular level. Transport of nutrients and energy substrates can't really pass through easily across that cell wall, that cell membrane, right? Because of that bogginess. There's lots of other players in the field now. Free oxygen radicals, reactive oxygen species, all these other kinds of things that are mucking up the works and disintegrating at the brain level, synaptic connections, and at the peripheral level, communications between different cell functions, excretion of different, endocrine peptides. That's the word I'm looking for. Neuropeptides and cellular peptides, somatic peptides, but also thinking about the release of ATP and that sort of thing. The bioavailability of these bioenergies are also blocked. And so that rewires this individual. It changes their original blueprint for how they were going to walk through the world. And I kind of touched upon this next slide a little bit earlier, but talking really about the threat system. And I'm just going to mention the polyvagal theory. It in and of itself is a topic, for its own webinar. But the developmental trajectory of the threat system is becoming more and more understood because of these negative effects of these adverse experiences, particularly around maternal deprivation or inconsistent care, where the caregiver is unable to maintain those buffering effects on cortisol and the amygdala reactivity, whether it's because of the way they're engaging with the infant, or possibly because of a lack of trust, because of past experiences, and the infant doesn't recognize them. The infant recognizes their mother, right? They recognize their mother from sound, smell, sight later on down the road, but a lot of it is smell. And if you look at the amygdala, how it's positioned in the subcortex, the amygdala, two almond structures right on either side, inside the temporal lobe, right in front of it is the olfactory bulb. Sense of smell is highly connected to our threat detection system. When this threat system is activated, it activates the autonomic nervous system, and it also through the vagus nerve. And that's this polyvagal theory. The vagus nerve is activated, and it innervates supradiaphragmatic, but as well subdiaphragmatic organs, because when you activate a fight or flight response, right, a stress response, remember what happens? Non-important or non-vital organs get hypoperfused. The blood is shunted from those organisms and then redirected to those fight or flight systems, right? Kidneys, brain, heart, and lung. The gut gets reduced shunting, the skin gets reduced perfusion. And how does that impact the individual? Is it possible? Again, this is another frustrating thing I think a lot of clinicians have is we want it clean. We want a straight line. If this, then this. We're human beings. We are messy. We are messy organisms, and there are no straight lines. Even in the lines that we used to think were straight, we are now discovering, right? We used to think these people didn't feel pain. Straight line. And now we know that it's way more complicated. They do feel pain, but they have an immature descending pathway to modulate the pain. So they have a prolonged experience of pain, right? So there's nothing straightforward about us. We are messy organisms, and we need to embrace the mess if we're really going to care for these individuals in a thoughtful, biologically and soulfully relevant way, right? Preserving their full potential. Alterations to the threat system lead to increased anxiety and attentional bias towards or sometimes away from the threat, but these individuals also become hypervigilant. So, people that are very jumpy, you kind of wonder, what's their backstory? Why are they so jumpy? People that are anxious, children that have been reared in dysfunctional families have lots of anxiety. They have lots of anxiety that they can't articulate. And the same is true for the patients that we serve. They can't articulate it because the stress experience, the trauma occurred or was initiated during pre-verbal time in their life. And so they can't find the words to express what they're feeling. So they just feel all these feelings bottled up inside that doesn't feel good, and it affects them autonomically, right? They'll get tachycardic. They'll get diaphoretic, and they can't articulate why. So there's lots of connectivity here. If you're interested in more information around this concept, I would invite you to look up the work around the adverse childhood experience study. The imagery here I wanted to share with you is when they looked at the amygdala and its connections to the orbitofrontal cortex, again, a segment of the prefrontal cortex, they see this hypertrophy in the setting of chronic stress. Again, it's that hyperactivation, right? So in the HPA axis, you kind of see the threshold for stress gets lower and lower because stress response, your ability to perceive stress is supposed to keep you safe. But if it's not working, well, we got to turn the dial down, right? And then it kind of becomes the threshold is too low and everything disrupts you. But it's because you're wired for that. You know, I hope I'm explaining this okay, and I hope you're finding this intriguing. I did want to share a little video that talks about the amygdala, and so hold on a sec. It's like a 5-minute video, and I think you're gonna. I hope I did this right. Hold tight. All right, here we go.
I think it's a distraction because, I mean, it's true in the sense that the hippocampus is necessary to have a conscious recollection of some past event. And the amygdala participates in unconscious memory, but we shouldn't really taint it with the Freudian concepts because that adds a lot of baggage. The amygdala is an unconscious processor because it's just not connected with the conscious system. It's kind of like, you know, by default unconscious, as opposed to being, in the Freudian sense of unconscious, something that was conscious but was too anxiety-provoking and therefore shipped to the unconscious. The amygdala gets direct sensory information, and it learns and stores information on its own, and that information that's stored then controls emotional responses. The connectivity is hardwired. So one way to think about it is that a rat will respond to a cat without any learning by freezing, raising its blood pressure and heart rate and respiration and releasing stress hormones. But it will also respond to a stimulus associated with the cat and have the same responses. So you don't learn how to be afraid. Your amygdala doesn't have to learn what to do. It learns what to do it in response to. So it learns what stimuli it should respond to. So it's learning and memory in that sense that we call an implicit kind of memory, where you don't have to have any conscious involvement. Whereas the hippocampus is necessary to have a conscious memory. So yes, they do participate in conscious and unconscious memories, but not in the Freudian sense. But there's a whole other side of the amygdala's role in memory, which is that when the amygdala is activated and all those hormones and other things happen, they get released, that provides information that feeds back to parts of the brain like the hippocampus and allows them to store their memories in a much more efficient and strong way. So we know that emotional memories are stored more vividly than other kinds of memories. It used to be thought that they're more accurate, but in fact now we know they're not more accurate. They're just sort of more vivid and strong in the personal sense, but they can be highly inaccurate. This is shown by studies of natural disasters and so forth. Well, not always so natural, but like the Space Challenger, the shuttle. Space Shuttle Challenger explosion. A lot of people witnessed that, and they were studied almost immediately by psychologists who made notes of exactly what their responses, what they were experiencing at the time. And then a year later, they were surveyed again, and the responses were completely different from what they remembered originally, and then several years later, it completely changed again. So what we remember is not necessarily what we experienced originally. So the accuracy of those memories changes over time, but their strength in terms of your subjective feeling that it was a really powerful experience is there.
So let me pull my slides back up. I hope you found that interesting. I'm going to come over to the chat and see if any. Okay. I hope you found that interesting, and you might be thinking, okay, great, Mary. So what? So now what do we do with all this information? Well, I just want to kind of bring you back to the definition of trauma, right? Just so that we're working from the same knowledge place. It's an event or a series of events or circumstances experienced by an individual as physically or emotionally harmful or life-threatening, with lasting adverse effects on the individual's functioning and mental, physical, social, emotional, or spiritual well-being. We're really starting to grab this and recognize this in a meaningful way within the world of pediatrics and neonatology. We've got a couple of models that acknowledge this. There's the pediatric medical traumatic stress model. This is a more recent reference to it. The original publication, I believe, was 2006, where we recognize the impact of trauma exposure for children in that system, in a hospital system. And we apply knowledge about trauma to policy and practice in order to prevent the re-traumatization and reduce the negative sequelae. That's really what the pediatric medical traumatic stress model is talking about. More recently, in 2016, DeGatter et al. Proposed this conceptual model of infant medical trauma, that as a result of NICU care, the infant experiences increased stress, parental separation, and pain. All of these are stress, right? All of these are stressors. And that the collective experience of this stress may contribute negatively to the infant's allostatic load. Allostatic load is when the system, when there's too much stress hitting the system. Homeostasis is you're chilling and we're buzzing. Allostasis is a stress response, not necessarily bad, right? It's allostatic response helps us adapt to a given stressor. But when that stressor is repeated and ongoing and becomes chronic, it is then called an allostatic load. And that's the thing that derails the healthy development of the individual. And so I take this and bring you to this idea of a trauma-informed system. And that trauma-informed systems recognize the potentially traumatic nature of medical events and medical care for infants and children. And it incorporates an understanding of this into the organizational culture, policies, and procedures. And that each encounter with the healthcare team is informed by this awareness that trauma and that medical events can be traumatizing. And that trauma-informed healthcare also incorporates an understanding of the impact of past experiences for the child, right? So it's a cumulative effect, right? It's not like, well, they've been here for 15 days or they've been here for 60 days. Haven't they gotten used to it? No, it's cumulative. And so I take that model or that information and juxtapose it to what they call the principles and values of TIA. It's called a trauma-informed approach. There are 5 principles, and it's about safety, choice, collaboration, empowerment, and trustworthiness. And these are put forth by the Substance Abuse Mental Health Organization of the United States. So I've shared with you an awful lot of information. I know we're running close to the line here. I'm going to invite you to just hang with me for a few more minutes and ask you now. So you've heard a lot of information. What do you think are the implications of an increased awareness of the long-term socio-emotional problems associated with preterm or low birth weight infants for clinical practice and public policy? What do you think are these implications? And of course, I have thoughts on them, but please feel free to throw some stuff into the chat box. I would love to hear your idea. Because for me, the implications are an invitation to adopt evidence-based best practices. And these evidence-based practices that have been coined for the neonatal and infant patient population actually transcend all patient populations. And I've worked with groups actually in adult geriatric care to take these concepts and identify what are the best practices around these domains that address the human needs of a hospitalized individual. We need to protect theirs. And these also align with the Joint Commission's elements around, oh goodness gracious, what do they call them? When they do the satisfaction stuff, like HCAP scores and that sort of thing. I mean, these core measures are really quintessential. I mean, that's not the reason why you should adopt them, right, for your parent satisfaction. I mean, although that's important, you should adopt them because they're the right thing to do for your patients. Protecting sleep, managing pain and stress, and that includes assessing pain and stress and enrolling the parents, involving the parents. Activities of daily living, that's postural support, eating experiences, and skincare practices. Obviously, the family is crucial in everything. And then the healing environment. And the healing environment is not just the physical space, but it's the physical space with the human environment, that's us, right, the team, and then the organizational structure. And for the 2020, there's a burgeoning body of research now addressing the role of play as a trauma-informed, evidence-based intervention. And play, I mean, when I first thought about this, I go, what's play for a baby who's 24 weeks gestation? Well, you know what play is? Play for that baby is skin-to-skin care. Play for that baby is listening to their mommy or daddy singing to them. Play for that baby is maybe just hearing them read a story. Play for an infant is encounters with, it's developing that relationship with their primary caregiver, their parents. And all of that, when you look at these ideas of safety, collaboration, choice, empowerment, and trustworthiness, there's an interplay there, right? Certainly safety for all of these, right? Protecting their core identity, protecting their blueprint, collaborating with parents and the patient. What does patient collaboration look like? Cue-based care, choice, empowering the infant to demonstrate how they feel about a situation, and changing the direction of a care encounter based on that assessment. So these are relevant practices that I think really what we need to do is we need to more consistently advocate for these experiences to become hardwired into our cultures of care, and set that expectation not just for the inpatient experience, but for the outpatient experience as well. We know in animal and human research, there's conclusive evidence that these early adverse experiences negatively impact the neurobiology of these developing infants, which undermines their lifelong health and wellness. That the effects of early life adversity have been observed in the neuroendocrine system, neural circuitry, as well as the threat system. So again, these are key players in having a healthy quality of life. These early experiences affect the development of these systems, and with these caregiving experiences, if they're positive, awesome, we can mitigate the negative developmental trajectory. But if they go unchecked, well, we see this higher incidence of psychopathology and other adult life-changing morbidities that actually reduce the length of their life. That's not the right word, but you know what I mean. Trauma, specifically neglect, has the potential to alter neurobiology. And so neglect, remember when I mentioned about maltreatment, that's really neglect. When we neglect to address their individual needs, their psychosocial needs, their needs for comfort. And interventions, though, what we know is can make a difference. They can improve the outcomes of these individuals in meaningful, measurable ways. So I have to end this portion of the webinar with a Dr. Seuss quote. That to the world you may be one person, but to one person you may be the world. And I want you to be empowered and encouraged by that truth, that you are the difference in that caring moment for that infant. It can be for better or for worse, but you hold the key to making it better. But as I say that, right, I mean, we've got tons of competing priorities. And how do we keep abreast of all of this research and evidence? I mean, gee whiz, this is like my full-time job, like keeping abreast of it, and I'm blown away. I'm excited for sure, but I'm blown away by all the new information, all the new research that's coming to light. And my goal is to cramp down that. Do you know that there's a 17-year gap between research and making it a standard of care? 17 years. So let's bridge that. Let's really like narrow that down and change that. And one of the ways I want to invite you to address that is to come to Lisbon in February for the Science and Soul Conference. I'll send you a brochure. It's February 28th and 29th. It's not that expensive to fly to Lisbon. And because you guys have been so gracious, and of course now because I'm going over my time, I'd like to offer you a special reduced rate. I'm actually giving you the early bird rate. The current registration fee for the Congress is $550 for coming to this webinar and spending this time with me. If you apply this particular code at the checkout, you will get $125 off your registration fee, which will bring it to the $425 early bird registration. I'm going to invite you. I mean, I come to my website and check it all out, but give yourself the knowledge of the gift of knowledge, networking, and restoration. I've had people say that it changed their lives, and that was after the first one. This is our third Congress. And it was after that and getting that kind of feedback that really made me say, I need to do this. I think we've got more clinicians that really are trying to figure out how do they restore themselves? How do they fill up their cup of knowledge, but also that cup of caring, the cup of kindness that lies within all of us, right? So I'll send you this slide deck. Please come and visit me. Ask me any questions. I apologize for going over time. I guess I was too social at the beginning. You will get a link tomorrow for the replay of this. But in the meantime, I will send you the handouts. I will send you the brochure for the Congress. In the handouts, you'll see the code. So you won't see the code in the brochure because this is just special for you guys, because I know this is a busy time of year, and I'm really grateful that you took this time out of your life to spend with me as I kind of share what it is that I'm learning about this, and that's it, I guess, you know. So Merry Christmas and Happy Holidays to all of you guys. I'm here for another 5 minutes I've got. If you want to throw your questions up on the board, if not, email me with your questions, okay? Because I know sometimes you have to chew on it. But I'll stop talking now, so you can post something. If you have to run, I understand. Just shoot a goodbye, so I'll know that you're jumping off. Merry Christmas, Sharon. Merry Christmas, Tammy, Casey, Anne, Elise, Cheryl, Jennifer. Thank you so much. Oh, you're most welcome, Cheryl. I hope it was interesting and engaging. Well, I know you guys are busy. I'm going to let you all go. Mwah. Bye, everybody. Thank you.